Now I am very pleased to introduce Dr. Anna Shah. Dr. Shah attended the University of Missouri, Kansas City for both undergraduate and medical school. She went on to complete her neurology residency at the University of Michigan, where she served as chief resident in her final year. She completed her fellowship in multiple sclerosis and neuroimmunology at the University of Colorado, and then joined our team at the Rocky Mountain MS Center. Thank you so much, Anna. Dr. Shah.
Hi, everyone. Good morning. We'll just go ahead and get started. So I'm going to be talking about women's health and in multiple sclerosis. So here's a little outline of what we'll talk about today. We'll start off with why are women more susceptible to MS. Then we'll talk about all things pregnancy, so including prepartum, pregnancy, and the postpartum period. We'll go on to discuss MS in menopause, and then a little bit about socioeconomic implications. So what do we know about sex differences in MS? And we know that the rate of difference between women acquiring MS versus men is approaching 3 to 1, which is really interesting because if you look at some studies dating back about 50 years, the rate was probably closer to 2 to 1. And so that brings up an important question is why are women more susceptible to this disease? Another point that's interesting or important to make as we go through the talk is really this ratio difference in terms of diagnosis or prevalence of MS really is most prominent after puberty or the onset of the menstrual cycle and right before menopause, giving a lot of emphasis on the thought that sex hormones like estrogen and progesterone play a big difference and why we see this difference between men and women. So what exactly are these causes of increased susceptibility in women? As you all know, there is not one specific thing that causes individuals to acquire MS, or there's not one particular reason why people get MS. So when we look at potential reasons why women might be more susceptible than men to this disease, we think about 3 different things. We think about the genetics, we think about the hormones, and a little bit about environment. So when we think about the genetics in particular, we could have a whole talk about just genetics and MS, but recently they've done these studies called genome-wide association studies, where they've really found over 200 different genes that make up just about 50% of the genetic causes of MS. And there's one in particular that accounts for about 10% of MS cases, which is the HLA DRB11501, which I promise we will not quiz you about. But it becomes important because one of these genes that they've identified as being a potential reason why people get MS is particularly on the X chromosome. Now, what exactly does that mean? How many of the cases does it contribute to? I think we don't really have a good sense of that yet, but certainly something that's interesting. Another thing that we also know from the genetic standpoint is there is this feature called methylation, which is just our way of saying it's a code for some genes being turned on and some being turned off. And we know that the way that some of the X chromosomes, the way that they're methylated or turned on and off in males is quite different than females. And this seems to have an impact on some of the cells of immune functioning. So again, how much does that particularly impact women getting this more than men? Hard to know, but I think it certainly plays some sort of role. If we go on to talk a little bit about hormones, and we'll talk about pregnancy in just a little bit, we know that our sex hormones, particularly estrogen and progesterone, are huge modulators of our immune system. We know that periods of time where there's a lot of estrogen, like during times of pregnancy, there tends to be more of a protective feature against MS disease activity. And periods where there's less of that, for example, in that postpartum period where you expect a sudden dip in these hormones, there tends to be more MS disease activity. It's interesting in mice models of MS, which is what we call EAE, they've actually shown that higher levels of estrogen actually help with remyelination. So I think certainly an area that our field is continuing to look into. We know that estrogens at low doses, such as those with menstrual cycling, tend to be immunostimulatory, meaning stimulate the immune system, whereas estrogens in high levels, like during pregnancy, tend to be more repressive of the immune system. The other thing that's really interesting from a hormonal standpoint is actually looking at the age in which a woman develops her first menstrual cycle. We know earlier menstrual cycle tends to be associated with a higher risk of development of MS. And then if we go on to the environment, now this is something that, again, does it really account for the increased susceptibility in women? Hard to know. We know smoking certainly increases one's chance of development of MS. And we know just from natural history data that there has been an increased rate of smoking in women. So could that be playing a role? Absolutely. Other things that we think about contributing to our risk of development of MS include viruses like the Epstein-Barr virus, which is EBV. And then we know that vitamin D exposure as well as sunlight exposure plays some sort of role. And could we be contributing to this by more women moving into the workforce and moving indoors? Potentially. Again, not a ton of great robust data, but certainly valid hypotheses. So let's jump right into the all things pregnancy category. So when we think about fertility, a common question that we get asked in clinic is, does MS play a role in my ability to get pregnant or my fertility status? And there haven't been any good studies really looking at pregnancy success rates in multiple sclerosis. We do know from some studies that women with MS have fewer biologic children than the average population. And now, again, in some of these studies, there's big limitations, particularly knowing why that is. And is it because these women were diagnosed with MS and there's concerns about having children? Is it because there's a higher component of fatigue? Is it because there are some fertility issues? And I think that's a place where we need a little bit more information, which is a common thing you'll hear me say throughout this talk. There is something called anti-Müllerian hormone, or AMH, which really is an indication of ovarian reserve. And what we found in one small study was there is no difference in this level in women with MS compared to women without MS. In general, about 12% of the general population will use assistive reproductive technologies, and there have only been a handful of case reports looking at this in people with MS. They have found that there's increased MS activity within 3 months of using these type of technologies, things like IVF. But I would say we take that with a little bit of a grain of salt, particularly just because, as you all know, there's more case reports reported when something goes wrong than when something goes right. So it's hard to know exactly how much of an impact that has. I think it does bring up the important point, though, that if this is an avenue that you are pursuing, it's important for your neurologist to be aware, particularly there are just so many different vehicles of ART available. So that way they're in good communication with your obstetrician. In terms of contraception that's used, there are a lot of mixed reports about the effects of hormonal contraception on the development of MS and how patients do when they do have MS. There is everything ranging from it's got a poor prognostic indicator to being a positive prognostic indicator. So I don't think anything that we can take substantially away from that. But what we do know is that it doesn't really seem to affect disease progression or disability associated with the disease. So let's get into the bulk of pregnancy. So here is a really nice illustration that shows what relapse rate look like preceding pregnancy, during pregnancy, at the end of pregnancy. So if we look at this chart, that area that's shaded in the darker gray is really that period of pregnancy. The line to the left kind of shows you what disease activity was like on average in this study prior to pregnancy. And what you really see is there's a significant decrease in relapse rate during the period of pregnancy, particularly during that third trimester, where we have such a significant increase in are estrogen and progesterone, particularly related to the placenta. And this is also important because, as we all know, pregnancy is what we call an immunotolerant state, meaning the woman's body has to change quite a bit because you don't want your immune system naturally affecting the fetus. So I think that plays a role quite a bit too into the decreased disease activity during pregnancy. What you can see is on the right side of that gray shaded box is there's a significant increase in disease activity in the postpartum period, really limited to those first 3 months right after delivery. And we think that has a role to play with that drop off of the sex hormones. So common things that I think are important to touch on is with pregnancy planning, probably one of the most common questions that we get asked is, when is a good time to get pregnant? And that's a really hard question to answer. And part of it's limited by timing. And so if we say, what is the most optimal situation? The most optimal situation is really when we say your disease activity is as well controlled as we can get it. And you're on a good disease-modifying therapy, which we'll get into in just a minute. Another common question we get asked is, what type of OB should I be seeing? And I think there's not a ton of good data about this. Probably a midwifery service is less optimal than seeing a obstetrician, but there isn't any data showing a difference in outcomes when looking at regular OBs versus high-risk OBs. Vitamin D supplementation is incredibly important during pregnancy. There have been a few small studies showing lower vitamin D intake of the mom during pregnancy increases the risk of baby developing MS later on. So vitamin D supplementation is an important piece during pregnancy. And thinking about the use of symptomatic medications is also an incredibly important piece. So there are certain medications, things that we use commonly, like dalfampridine or Impera, or baclofen is another common one, that are not compatible or safe with pregnancy. So important to talk to your neurologist about that. Another thing that's important to know is kind of planning for delivery. So we get asked often, am I allowed to have a vaginal birth? Am I allowed to have a C-section? And the true answer to that is you're allowed to have babies the way that you want to have babies. So what do we know about babies that are born to women with MS? We know that babies' birth weights are slightly less compared to women without MS, but not at an increased risk of ICU stays or things like that after birth. In this study that was done looking at births in women with MS from the 60s to the early 2000s, they did find that women with MS had more frequent inductions and operative intervention during delivery, meaning things like going on to cesarean section. I think it's hard to know if that is something that would be as applicable now, just because we're in a different era of disease-modifying therapy. And probably most of those, like I said, it was a study from the 60s through the early 2000s, were in women that didn't have adequate early effective immunotherapy. I want to go through the rest of this with just the caveat that there are significant limitations in our knowledge about the safety of DMTs in pregnancy. So a lot of what we use is based on small case series and things like that. There's probably the most robust data behind the injectable therapies and their safety during pregnancy, primarily just because they've been out the longest. There is a slight caveat with the oral therapies, particularly with the S1P medications. The most commonly heard about one that we have data about is Gilenya or fingolimod. And we know there is a twofold increased risk of major congenital malformations, primarily congenital heart disease, but also expanding to things involving the kidneys and musculoskeletal system. And there is always the risk of rebound disease activity, which is really saying there's more disease activity than there was prior, and that's with withdrawal of those therapies. There is not a ton of evidence about the fumarate medications during pregnancy. There's one small case series showing a slightly higher risk of congenital heart disease, but again, nothing's too substantial. One of the things I want to spend just a couple minutes on is talking about natalizumab or Tysabri use during pregnancy. There have again been a few small case reports showing that there's an increased risk for congenital malformations, primarily looking at congenital heart disease. I would say we take that information slightly with a grain of salt, because in this particular case series, the children or the infants that had the congenital heart disease were also twins, which is an independent risk factor for the development of congenital heart disease. There has been known hematologic abnormalities in babies born to moms that are taking Tysabri, particularly during the 3rd trimester. So one of the ways that we've tried to approach this is perhaps continuation of Tysabri through trimesters 1 and 2 with cessation around week 30 to 32. And really spacing out Tysabri to perhaps every 6 weeks seems to help with the reduction of these potential side effects, but also decreases that risk of that rebound disease activity when Tysabri is stopped. The most common medication that we use here at our center, and I'll just go through those pretty quick, is usually one of the anti-CD20 infusions. So the ways that we really approach that is by saying, well, let's take a little bit of background information about these medications. The half-life of most of these B-cell depleting agents is around 20 days. And half-life is just a fancy way of saying how long does it take for the drug to decrease in your body. So it takes about 5 half-lives, or about 100 days for the drug to leave the body. And we theoretically say B-cell depletion, the effects of these medications last about 6 months, but we know they probably last longer than that. So what we typically tell our patients if we're doing pregnancy planning in this situation is to wait for about 2 to 3 months post-infusion. And if you do that and you try and get pregnant, then we know that you'll have coverage during that 1st trimester, which is really the highest risk of relapses throughout pregnancy, even though the risk of relapses during pregnancy is much lower. And we also know that the placenta is not fully formed until about 18 to 20 weeks. And these medications don't really cross the placenta until the 2nd trimester. And then the next important piece is to talk about the postpartum period. And it's really important to make sure that we're planning for the postpartum period when patients are still pregnant. So we typically see patients during that 3rd trimester and talk about what to do in that postpartum period. And a really important piece about that is, when do we restart disease-modifying therapy, and what is that relationship to breastfeeding? And again, not something we have a ton of data on, but hopefully something that we'll acquire here in the next year or so. So there is no evidence to suggest harmful effect of breastfeeding on MS relapses. In fact, it's quite the opposite. So when they took a meta-analysis of 17 different studies, which is basically just saying taking multiple different studies, putting it all together, they saw that breastfeeding was really associated with a lower risk of postpartum relapses compared to those women that weren't breastfeeding. Now, the caveat to that was this was looking particularly at exclusive breastfeeding, meaning no supplementation with formula or things like that. So what do we know about safety of medication use in breastfeeding? Again, another area where I think there is room for development of more information, but we know how big the medication is and which phase of breast milk a mom is in, whether it's the initial breast milk, which is called colostrum, if it's that middle phase, which is transitional breast milk, or if it's the later phase, which is mature breast milk, makes a difference into how these medications are given. I'm really going to go back to that original schematic we had and really highlight the anti-CD20 infusion therapies. What we know, or what we're trying to learn about these medications, is that they're really large molecules, which means they don't pass into breast milk easily. And of course, they're digested in the oral system, which is why we don't give these medications orally. So we really think that there's safety in using these medications once mom's milk is mature. Just again, we don't know how much passes through in those earlier phases of breast milk. An important study, or an important thing that we're working on here, is saying, well, in our mothers that are taking these treatments, what are we seeing happen to the babies? Because it's really important that babies' B cells are okay, because like you heard from Dr. Alvarez's talk, the B cells play an important role in our ability to mount responses to vaccinations. So we have a small group of women that we've checked this in and really found that there hasn't been an effect on babies' B cells in women that are breastfeeding on these therapies, which I think is great news. Let's take a leap forward to just talking about menopause and MS. There have been 2 big studies that have shown that there is a slight increase in disability progression, particularly in that period around menopause. And the question really is why? Is it related to this drop in estrogen? Is it related to unmasking the aging brain? And that's something that we don't quite know yet. One of the things that's important to point out is that in general, women without MS are describing this period of cognitive fogginess or impaired cognition during menopause. So you can only imagine that that's more accentuated in our patients with MS that may already have these symptoms preceding menopause. Another thing that's important to point out is hot flashes typically elevate the body temperature, hence their name, and can lead to what we call pseudo-relapses or recrudescence, so emergence of those old MS symptoms. And that might be something that they're taking into account when they see the slight increase in disability progression. And I think the big major thing is, well, what do we still need to learn about this stage? And the answer to that is a lot. There have been a few very small studies looking at the use of hormonal replacement in this period, and there hasn't been anything substantial, but I think that is certainly an area where more information is probably going to be coming out in the next year or two, and I think that'll be really important to our patients. I just want to take a few minutes now just to talk about socioeconomic implications for women with MS, because I think this is also a really important topic. We don't have any good big studies here from the US, but they did do this study in 2017 looking at just over 800 women in the 8 European countries. And interesting points that I kind of picked out from these survey results is that 21% of women were misdiagnosed before being diagnosed with MS. And most of these women were diagnosed with some sort of psychiatric disease or some sort of pain syndrome, which I think is really interesting, particularly if you compare it to men that were misdiagnosed, which was less than 10%. 41% of the women in this study had separated or divorced their partners after their diagnosis, with the vast majority noting that their MS diagnosis had played a role in this decision. And 37% reported having a change in family planning because of their diagnosis of MS. And now the change in family planning might be having no children, or if they were planning on having 3, having 2 children. So it's a pretty broad category. 66% noticed that MS had affected their employment at some point, and 38% had left employment altogether, with 60 to 80% either having lost their job or exiting the workforce about 15 years after their diagnosis. So again, not insubstantial numbers. So just main takeaways from this: MS affects women at a higher rate than men. Pregnancy is a protective period for women with MS, with an increased risk of disease activity in the postpartum period. Significant socioeconomic implications for women with MS. And I think the biggest thing, which is that line I have in bold there at the bottom, which is really just that we need more research so we can better support our female patients with MS. And of course, I can't end a women in MS talk without having a picture of my 2 little nuggets. So.
Thank you so much, Dr. Shah. One last reminder to please submit your questions on index cards or using the chat feature. We have one more presentation today and then our Q&A session.